Hi, everybody. I want to welcome you all to the last pediatric grand rounds of the academic year. This will be our final grand rounds, and we'll be reconvening again in September. And before I introduce the speaker, I'm going to ask Sundrain to come up in a second, but I just want to first of all thank Sundrain and Roberta Keller, who co-chaired this year's Grand Rounds Committee. Thank them for all their hard work. And Sundrain would like to say a few words as well about the committee.
So first of all, of course, Roberta and I sweat, tears, and just work really hard, hours, late night meetings to make this all happen. Right, Roberta? But the truth is that we have a fantastic planning committee. Some of them are in the audience. Actually, I always want to recognize the most loyal member of our planning committee in terms of coming to grand rounds, and that would be Jim Byers. So, Jim, thanks so much for being such a great member of our planning committee, being here every week. Meg, coming from the general almost every single week. Matt Zinter, here very frequently, always having really good ideas for grand rounds. And because there's a lot of people, probably some on Zoom that in the committee that I won't all mention, but some people are stepping down this year. So if you're interested in becoming a member of Grand Rounds, it's an enormous amount of work. It's 2 meetings a year. And then maybe an occasional email to say, do you have any ideas? And it's a really fun group, and it's a really nice way to contribute to sort of celebrating what we're doing here at our department and helping lift up people that you think really should be in the spotlight. Speaking of spotlight, we're going to put 2 people in the spotlight. I'm only seeing one of them, but Grand Rounds really wouldn't be possible if it wasn't for 2 people who help with all this planning, deal with all the annoying AV issues, make sure there's food, make sure that everybody shows up on time, that we can hear everybody, all of that kind of good stuff, and currently also that we get CME credit. Thank you, Myla. And that would be Myla, and I hope she comes Marcella, and we have a little bit of thank you for you. Thank you.
All right, thank you, Sundrain. And now it's my pleasure to introduce Dr. Maggie Robinson, who again is going to be our last but not least final speaker, the honor of this final speaker for our academic year. Dr. Robinson is an assistant professor here in the Division of Critical Care, and she's associate program director for the Pediatric Critical Care Fellowship. She completed both her residency and fellowship here and is currently pursuing a PhD in health professions education. She does research on autonomy and supervision, and that work's been presented at numerous academic conferences, including the PAS. Today, she'll share with us the work she's doing to examine the factors shaping resident voice, decision-making, and patient care ownership in the clinical environment, and share practical strategies for promoting meaningful training involvement while maintaining appropriate supervision. So please join me in welcoming Dr. Robinson.
Dr. Hirsch, when I found out that I was giving the final grand rounds before the summer break, I obviously thought that they were bringing in a really fun speaker with a really interesting topic, kind of like the end of school year party or field day. And I actually was able to practice this with my parents the other day, and my dad had fallen asleep within 10 minutes. So I'm not sure that it was as fun as I was hoping, but maybe they will be a tougher crowd than you all will be. Before I get started talking about pediatric training, I also had thought that I was going to be giving this talk on the year anniversary of Satish Rajagopal's passing. It's actually a year and a week since he passed away, and so I wasn't going to include it because I thought that might be kind of weird. But I had someone text me out of the blue about him the other day, and so I took that as a sign to include him. It's not totally random to be talking about him because he was one of the best supervisors I had in my training, and it's not because he was kind of famous for giving a lot of autonomy, and I've never seen someone be so genuinely surprised by labs and vital signs on rounds as Satish was, because he'd never heard of any of those things. Like, that was the first time he'd heard of anything on rounds. But the way he could support me through situations where I felt out of water, like I shouldn't be involved. I got procedures. I was successful with procedures with him by my side that I never would have imagined being able to do. And we actually were able to give a faculty development session a few years ago on autonomy and supervision. It was basically just me asking him questions. And I asked him how he was able to give so much autonomy. And he said it was because he trusted the system. And so then I looked back and was like, so maybe it wasn't me he was believing in, but he was believing in the system, because he did look very shocked whenever I would get a procedure. But if you could humor me for a moment, and if we could just take a minute and think about a supervisor that you trained under who meant a lot to you. And if no one comes to mind, if you can just think about something funny that has happened at work recently, because Satish also just made every day at work kind of hilarious. And so we'll take a minute to do that. April probably feels very awkward. I'm not sure I can hold out for a whole minute, but you get the point. And I think if Satish were here, he either would have fainted or he would tell me I was stalling. And so I'll get on with my talk. And these are the objectives for the talk, but I think the more important thing is I'm not going to try to convince you all to be more like Satish, because I don't think any of us could do that. But I also think that giving autonomy is a lot more complicated for most of us than just being able to trust the system. And so why am I calling this the autonomy paradox? I've split the talk into 3 parts. And the first part is going to be me trying to convince you why autonomy might be the wrong endpoint for medical training. And then we're going to spend some time talking about how it's more than just the supervisor trainee that is shaping the development of the physician. And there's a whole lot about the clinical learning environment that influences that development. And then at the end, we'll be talking about this idea of patient care ownership and how it actually can motivate trainees to learn and become independently practicing physicians. I need to talk a little bit more about myself because I think it's important for you to know how I became interested in this work and to situate myself in the research that I've been doing. I grew up in Athens, Georgia. Go Dogs. And I was a psychology major in college and spent about a year after college in a lab on studying a clinical research group studying intracerebral hemorrhages. And then in medical school, I tried my hand at pipetting. Turns out I ruined a lot of assays, but I did try out basic science. And then I came to residency here, naively thinking that I was going to meet a patient or learn about a disease that really inspired me and that would become my life's work. And what really happened is that residency was very different than what I had expected it to be. And I spent a lot of my free time. This is from a picture from when I used to run, but I would spend a lot of time on runs and downtime thinking about why my expectations weren't meeting the reality. And I think I had built expectations based off hearing stories from my family of doctors and from popular media. If you read this book, it's a very sensationalized account of being a house officer in the 80s, I think, 70s or 80s. And so that's what I came in expecting. And actually what I spent a lot of time doing was writing flush lock orders. So that jarring to me. I have my biggest fan in the front row. And so I simultaneously was developing an interest in critical care and met with the fellowship director at the time, who's in the back row here today. I thought she was going to be in the front row, but that's okay. And I was very nervous, and I knew this question was coming. She asked me what my research interests were, and I was like, I don't know, I'm going to wing this. And I rambled kind of like I've been doing about my experience in residency. And I was shocked by her answer. She said, well, you can study that. And I think I probably didn't do enough research before I met with her, because that is something she studies. So, but I was surprised and excited. And so during residency, I did a project where I tried to create a feedback tool where a resident who's working at night could elicit feedback from a daytime attending about a decision they'd made at night. I left my poster very small because all you need to know is it was a flop. Like, no one used the tool, even though people claimed they would be excited to use it. But when I asked people why they didn't use it, this quote from a resident really stood out to me, who said, most significant decisions were discussed with either the PICU attending or the renal GI fellows, so it didn't feel as though there were too many decisions I made on my own that needed feedback. And I was really struck by this quote, and it got me thinking a lot. And I think at first I was annoyed, because when I would tell people that, sometimes their immediate response would be, oh, like millennials are so, they're losing the plot. They don't understand what it takes to take care of patients, and they're not engaged, et cetera. And that annoyed me, because I am a millennial, and that's not how I was approaching my work. And I think through time, I've been able to become more agnostic about thinking about this quote and why the resident wasn't able to engage in the learning that was available to them. Meanwhile, I went to fellowship here, and this is actually in the entranceway to the PICU. It's a patient's drawing of their time in the PICU, and it happened to be a patient who was very meaningful to me in my training. And I am juxtaposing this like allegorical experience to also being very fortunate to have the support of my division and be enrolled in the Berkeley Graduate School of Education. So it was kind of two very disparate worlds, but I was always amazed that I was able to be learning in an environment that held such like big concepts of life and death and really sick children. Okay, I'm almost finished talking about myself, but today I'm on faculty in the Division of Critical Care and work in the hospitals in Oakland and San Francisco. And then I was going to offer money if anyone knew where this is, but I think at least a few people, if not here, but maybe on Zoom, know. But it is the University of Utrecht in the Netherlands. And I'm currently enrolled in a joint program between there and UCSF, and a doctoral program on health professions education. Okay, let's actually talk about autonomy now, but I think you can see how it was becoming a theme for me to be curious about why I wasn't getting the autonomy I'd expected, and if that meant I could still be a doctor or not. And I think this focus on autonomy, we need to go back a few hundred years, and kind of the Western medicine European view of how training happened was through the apprenticeship model. So the apprentice and the physician would be side by side, going into people's homes and taking care of the sick. And so it's a very obvious incremental shift from being an apprentice to becoming either taking over that physician's practice or going out on your own. And the supervisor is side by side for all of that. This shifted hugely once hospitals became the place where people received their medical care. And so it was centralized healthcare. And in order to be able to run the hospitals, they shifted the model to having house officers who were in the hospital 24/7. And really supervision was separated by time and space. And the attending would come in for rounds, and that's where like the teaching would happen and kind of the review of the decisions the house officers had made. That has shifted hugely again in the past 10 to 20 years, largely as a result of this publication, To Err is Human by the Institute of Medicine, which really focused on issues of patient safety related to the lack of supervision that was going on. And so in the United States, and I think especially in pediatrics, we've shifted to models where there's almost 24/7 oversight of trainees. This has been really widely studied about what it means for autonomy, how we supervise, how we support growing independence. But what I found in reading this literature is that I was still kind of confused, like what is autonomy? Is it free will? Is it the ability to make your own decisions? Is it the ability to make your own schedule? And obviously in medical training, definitely a few of those, if not all of them, are not really in existence. And yet we spend so much time focusing on residents and fellows being able to have autonomy that became kind of a confusing concept to me. And so in this paper, we tried to better understand what residents really meant when they were talking about wanting autonomy. And we took a qualitative approach and interviewed residents at 3 different residency programs. And in the interviews, I didn't ask specifically about like, what is autonomy to you, but it came up naturally that they would talk about decision-making being like how autonomy was manifested for them. And unfortunately, most of the time they weren't making decisions is what it kept coming back to, or the decisions they were making were like quite small, like I decided to replace an NG because it had gotten dislodged, but that was kind of their biggest memory of making a decision. And so I was concerned about that, but while we were reviewing the data, we also kept noticing this concept coming up that residents would talk about patient care ownership. And that was something that they felt when they were able to make decisions. And that became kind of a recurrent theme through our analysis. And so while decision-making is something that influences this perception of patient care ownership, it also was felt when the resident was the person who had the most knowledge of the patient. So if they had been on a rotation and in continuity with a patient for 3 weeks and the attendings kept cycling through, then that resident became the person who had kind of the historical data and was spending the most time with the patient or the family. It also was seen when they were recognized as the doctor. So if they're on rounds and they're referred to as Dr. Robinson instead of the intern, or their opinion was validated kind of in a group setting, that was something that also helped them feel patient care ownership. The fourth way in which they felt it was if they were the primary communicator. So even if they weren't the ones making the decision, they were the one explaining what was going on to the family or the one talking with the consultants. And then finally, if they felt responsibility, even separate from feeling responsible for a decision, but feeling like I need to know, like imagine being on with Satish, I need to know all the vital sign changes and all the lab changes because no one else is looking at it. So having that feeling of responsibility also led to feeling like they had ownership over patient care. Why is this all important? Is that learning was still happening when they were able to engage in the clinical care. And so all that to say, I feel like we are often hyper-focused on this idea of autonomy. And so both for trainees and supervisors alike, I think we should worry a little bit less about it. I was not joking when this quote has haunted me, and I've thought about it a lot. And so at the time I did this study, my secret purpose was to try to prove to attendings that we needed to allow trainees to be able to make more decisions. So I really focused on this relationship between the supervisor and the trainee. And I met with this powerhouse in education research, Pat O'Sullivan, who's here at UCSF, and told her about my interest and was really excited. And she laughed and said, it's a very niche joke, but she said, "You doctors are all cognitive behavioralists." And I laughed too, but I had no idea what she was talking about. And I think I've come to get a little bit better understanding of it. But what she was trying to say is, I was feeling like there was something I could change about the internal motivation of the resident, or something I could change about the supervisor's behavior that would support more opportunities for decision making. But actually, there is so much more that's influencing that phenomenon of being able to make clinical decisions. And so I wanted to go back and look at the clinical learning environment. Just to echo that, because I can't get enough of this drawing. The way I've been viewing it was, this is it, and that is the trainee and the supervisor at the bedside with the patient, and that is where I should focus my own research to make a meaningful change in how residents are involved in decision making. But actually, we're a very small cog in a very complex healthcare system. And so to study this, like for those of you who do Petri dishes, that is not very realistic. So I needed to take a bigger look at what was happening in the healthcare system. That led to this study that was just recently published, where we did a content analysis on those same interview sets, but looked at different narratives in them. And we used a pre-existing framework for how to understand the clinical learning environment, and divided what we saw in the stories into personal, social, and organizational factors. And then to represent complexity, we looked for places where there was tension between those factors. It's a very busy slide, but I'll pull out a couple of examples. This is a resident telling a story about being involved in patient's care and being uncertain about how the case was evolving for the patient, and having to leave and go to a clinic. And so missing 5 hours of this patient's exam, they weren't able to come to terms with their own uncertainty, and the patient ended up needing an escalation of care. And there was never a way for the resident to resolve this tension of feeling like they missed a changing exam. And luckily, at least in our own residency program, I think the leadership has worked very hard to overcome this one particular issue by switching to the X+Y blocks. This is another example where a resident on their PICU rotation, the structure was such that the cardiology team would round before the PICU rounds, and then they'd all come back around together, and the resident would be presenting an assessment and a plan, even though it was the first time they'd ever been exposed to the cardiology patients. And then the people at the top of the hierarchy, the cardiologists, would come in with an assessment and plan before the resident could even kind of work through their own presentation. And so here we saw conflict between, or tension between, a social factor and a personal factor. And why this matters is when the resident or the team wasn't able to resolve these conflicts or these tensions, it represented a loss of a learning opportunity. And so for both these residents, what they ultimately described was becoming disengaged with the work that was going on. And so in the second example, the resident just kind of stopped trying and moved quickly through their pre-rounding and didn't really work to come up with their own assessment and plan because they knew it had already been made. So in order to do this analysis, we looked at two pretty well-known learning theories. I'll explain them to those of you who might not be more familiar, but this is Vygotsky's zone of proximal development. The idea is that in the inner circle, there's all this stuff learners can already do on their own. And in the outer circle, there's stuff learners can't do even with all the support in the world. And then there's this sweet spot in the middle where there's stuff learners can do, but they need support to do it. So that's like where Satish supported me through those procedures that I thought I had no business doing. And the second theory I want to talk about is called communities of practice. And the idea here, it takes a social approach to learning where someone comes in as a newcomer into a community where the group has the same goal in mind. So in our case, it would be patient care. And they start out as a peripheral participant, but through gaining competence and gaining belonging in the group, they move to becoming engaged participants, then more active contributors, and then they really become central participants. And so I think this aligns really well with how we would ideally do medical training. Okay, this feels like a very random slide, but I promise it'll make sense. And I don't even know if we're supposed to do active crowd participation, but does it even know what this is on the left? A cronut, of course you all know. So it's the combination of a croissant and a donut. And then does anyone know what this is besides being a dog? It's half wiener dog, Dachshunds, and then it's half Chihuahua, so it's a Chiweenie. And so when we were doing the analysis of this study, we realized we could just combine these two really great theories and make something even better, which has been done since the dawn of time, I guess, with things like cronuts and Chiweenies. But we looked at how learning was happening and realized that in these stories of tensions, when the tensions weren't able to be resolved, what usually happened is that the participant or the resident would become marginalized from the group. And that was representing kind of the loss of learning. And the influences there of moving them in and out of it was these interactions of personal, social, and organizational factors. But those same factors could also pull the resident into legitimate participation, and that can move back and forth from being peripheral or central depending on the context. And interestingly, in our work at least, residents usually talk about not really minding shifting back and forth from peripheral and central participation because they recognize there's some situations where they just shouldn't be the central participant or the one making the decisions. And if you can stay in this zone, then you are in the zone of proximal development. Unfortunately, I don't really have answers to how to solve any of these problems, but I think a place to start is to just recognize both as a trainee and a supervisor when you see a tension happening. And I think by recognizing it, you can work to avoid that marginalization that can happen, that happens if it's not addressed. Okay. I'm going to speak the language of the basic science and clinical researchers here to draw you back in, because this has been a lot of kind of abstract educational theory research, but I was also interested in how I could translate what we were doing to actual interventions at the bedside that would make a difference for trainees and the learning that is happening or not happening. And so I was interested in how we could leverage electronic health records for educational purposes, because there's been a lot of studies that have shown residents spend up to like 80% of their day at a computer. And I think kind of serendipitously, Glenn Rosenbluth approached me to help him with a project he was doing that he had wanted to start because he was at the time very much into informatics and how that same idea of how we could leverage big data for resident learning. And he had been trying to create dashboards that residents could go to for learning metrics and had difficulty with getting engagement. And so we took a step back to try to figure out what kind of data residents were seeking or would be more interested in from the EHR. And so I thought this study has cool methodology where if the resident enrolled in the study, when they were on inpatient rotation, they would get a survey linked to a patient chart they opened. There was a limit to how many surveys they could get, but the survey would ask, what is your role for this patient in this patient's care? And then would you be interested in having feedback on them in the form of outcome data? And then if they answered yes, there were a couple more clarifying questions, but we were surprised that it wasn't even like, we weren't even getting to like what they would be interested in terms of outcome data feedback, because the large majority of the time they just weren't interested in feedback at all. And so we had over 900 patient encounters we looked at, and about 30% of the time they were interested in follow-up on that patient. This increased to a little less than 50% when they were the primary provider, or when they identified themselves as the primary provider. And there was no difference between pediatrics or internal medicine where we were doing the study. And so this is like the return of this haunting quote to me that it actually was not just this one-off with this resident, but there was something going on in patient care that was not engaging residents and wanting to seek feedback. We did ask why they wanted feedback or outcome data when they answered yes, and it's probably a hard to see slide, but the most common reason they cited for wanting feedback was when either they felt like they made significant decisions for the patient or they felt responsibility or ownership for the patient's care. So there's a nice thread for me there. But at the end of the study, we were kind of left with more questions than answers, and we decided the best way to further pursue research into the topic would be not to do retrospective work, but to choose a design-based approach where we could really study this habit of reflective practice and how residents were forming it or not. And so this is a work in process, but we created a report card that residents got 30 days after their inpatient hospital rotations. And the report included demographics on the patients. And then it also included some outcome data. So we would provide 30-day readmissions, so bounce backs of patients that occurred after a resident rotated off the service, and it had their initial admission principal problem and then their readmission principal problem, among other data. It had procedures that happened after the rotation, and then inpatient codes and RTs that happened after the rotation. And then finally, we also did our best to include cultures that came back or path that came back after the rotation. So when you do this type of research, you need a framework to use in your analysis. And for this, I can't help it, I had to come back to cognitive behavioral theory. So again, it's like, what is the resident doing that is driving their behavior? And for this, we used goal orientation theory, which is a way, it gives 3 different ways you can bucket a resident's feedback seeking behavior. And so the first way a resident decides to seek feedback is if they want to achieve mastery. So they really want to know what happens to the patient because they want to grow professionally. It's this like idea of growth mindset. The second bucket wanted to get feedback because they wanted to feel more competent than their peers. So that's called performance seeking feedback behavior. And then this is the best graphic you can find in the PowerPoint deck. But the third bucket is that they were performance avoidant. So they really just didn't want to seek feedback for fear of feeling like a failure, regardless of if they were actually a failure or not. And so we set this framework against our data. I should say we interviewed residents after they received the report to find out more about how they go about reflective practice and using the intervention as a setup to talk about like why they would or would not want to use something like that. What we found was there were kind of three lines of how residents approached their reflective practice, but they didn't align totally with these three buckets. I would say they were adjacent. The closest alignment is there were times when residents talked about wanting to go back in the chart to find out what happened because they wanted to build their schemas or their illness scripts. So ways in which they could grow professionally. And sometimes it was even they wanted to go back and have closure on a patient that they knew had died. And so reviewing the patient's course there. Instead of wanting to appear more competent than other peers, the second bucket was more about needing to resolve if a decision they had made was right or wrong. And so this was often driven by or motivated by when the resident actually was involved in the decision making, but it also the resident really took on the weight of like what they did affected the patient, and they needed to know if that was right or wrong, and kind of less about building those illness scripts. And then the third way, instead of having a fear of failure, it was more needing to avoid intense emotions of feeling very sad or blaming themselves for what happened. So it is similar to the middle bucket in that the residents were still blaming themselves for what happened. And I think that's in juxtaposition to the growth mindset where there's more of an acceptance of uncertainty in medicine, and that the system works in ways where you're not always in control of what will ultimately happen to the patient. And so that group was able to, I think, really engage and reflect the practice more than the other two groups. All that to say, I think what we can do now with that information is contextualize patient care. So this is where I think supervisors can help residents optimize their motivation for reflective practice. So I think speaking about how the course of patients goes, how a patient's course goes together as a group can be really helpful to take away that those feelings of like blame or also being able to accept the uncertainty that does happen in medicine. Okay, this slide is where I think things are going for me next. And I had started those prior two studies kind of before AI really took off. So I asked AI to make an image of what it would look like to have a AI resident on rounds. This is what it created. But I think what I am interested in is I think healthcare systems and education programs are pouring a lot of money into AI now and how we can use it to optimize education. But my same fears stand that if we don't understand why residents want to engage in learning and what motivates them to do it, that whatever tools we spend money on won't actually be that helpful. And it also, I think, speaks to some of the generationalism that happens where there's a big fear around if the resident's not working through writing their own note, if they're going to something like open evidence to answer like I've not yet heard of open evidence saying, I don't know, as the response. So there's you can seek closure to any question you have. And I think that can feel like shortcuts to a lot of people, but I don't think we really know how residents or trainees are using education or using AI for their education. And so getting a better understanding of that, I think, is where I want to go next. I have many people to thank, and so this is just a few of them up here who have really supported me in this work. I think if I had to guess, at one point it was like 90% of the group in here was from the Division of Critical Care. So they probably have their own motivations for coming, but I felt really supported by my division, and especially our chief, Jeff Feynman. And then Sandrain has been just like an ever-present mentor. And the last two, Christy and Bridget, have been integral in my master's and doctoral program education. So I'm very grateful for people letting me kind of take a untraditional path here. And I think I'm doing pretty good for time, so happy to answer any questions or just facilitate a discussion, because people usually have something to say about this. Oh yeah, do we have to use them?
Yeah, here, and you have a big Zoom audience, and I need to warn you, I think some family members I recognize some last names, so be careful. Be careful what you say.
So first of all, Maggie, that was great. Really helpful ways to start to think about this for a start for me, even though I'm in the advanced stages of my career. So I guess a couple of things sort of come to mind. So one is that, having a child who goes like through the educational system, right, through, elementary, middle, secondary school, I definitely noticed this kind of growth mindset. I bought the book and everything, everything, and that was like a really important way that the educators at those levels were really something they were really trying to foster in the kids as they develop. And then, so that's kind of the background of this question, but the three buckets, right? The growth mindset, and I can't remember the terms you used to describe the other two, but when you're in your supervisory role, does it help to understand first of all, can we build at this level the growth mindset? And does it also help to understand where your trainee is? And do they move? Do they move across the buckets? And how do we think about that as a supervisor optimizing?
That's a great question. And I would say most education theory and learning theory comes from K through 12 education. And so we're often applying concepts that have been proven in those worlds to higher education settings. And so I think a little bit to answer your question of if as a supervisor you should try to understand what bucket the trainee's in, I think that's probably in a way too hard for you to do. And so instead of trying to understand it, I think working to, in a way, I don't have a better way to say this except it's be more mindful of how trainees across the spectrum can learn. And so if there's a trainee who's may come across as avoidant, so they don't seem to be seeking feedback, and they may not be taking the extra step to find out what happens to their patient. I think there are things you can leverage as a supervisor to make them more interested. So either talking about yourself in ways that you kind of overcome potential guilt you have in patients you care for, and how you develop your lifelong learning skills, I think it's helpful for them to understand a different perspective. And it actually, I think more research or more interest will also be in this idea of professionalism and how it's shifting from being a physician as being a calling to potentially being more interested in it as like shift work and a job. And so if I clock out at 5 p.m., I'm not going to look till I come back to the day. But I think have to accept that and figure out how you can motivate them to learn it now.
Can I sneak in a quick follow-up question? Sorry, Jim, but have you looked at all to what degree those 3 buckets are actually contextual? Because that you don't want to learn in the ICU because you're primary care doctor and your mind is of course a criminal sin in my book, but it's also very understandable and vice versa.
Yeah, that's exactly. Luckily, some brain nodes might work really well. But if like residents would talk about, oh, when I'm on an inpatient rotation, but I want to go into primary care, I'm always looking at my primary care inbox, and I don't want to look back at the hospital patients I care for in the hospital when I'm not in the hospital.
Thank you for that really interesting talk today. So thinking about the educator trainee dynamic, one of the things I'm struck by is when giving feedback, right? An educator may think that they're providing feedback and the trainee may feel that they're never receiving feedback, leading to the advice to say specifically, let's sit down, I'm giving you feedback. And so now taking this and looking at autonomy, have you looked at the faculty versus the trainee experience? And does the faculty feel that they're providing autonomy, but the trainees don't really feel that? And is there a way to address sort of that communication so that everybody's on the same page?
Yeah, I could digress into like a bunch of tips on how a supervisor could make a trainee feel more autonomy, but I will at least say that there is a way to set the expectations of how you're going to provide autonomy. And so this gets back to a little bit of like, we can't all be Satish, but if you are someone who knows you're going to pre-round on all your patients as the supervisor before rounds, you can set the expectation that hey, we're going to use rounds as a way to work through like how you shift from being someone who's just going to report all the data to interpreting it, because I also already know all the data, but I expect you to come to rounds with an interpretation of that. And so to make it really clear what you're expecting, how you're expecting the resident to engage in the decision making, and I would focus more there than like I would try to avoid using the word autonomy as much as possible, because I think probably few of us in this room practice autonomously, even as faculty or attendings. And then I think there are ways in which you can have oversight would be in the background, and so leveraging technology for that, or separately checking in with nurses so that the residents do have more of a sense of autonomy. But I don't know. I mean, I think that would be interesting to see if you could name like, okay, I'm going to let you work autonomously for that's 4 hours, and then I'm going to check in at the end of it. I don't know if that might help reframe it for residents.
Thanks for a great talk. I'm curious, I really appreciate the framing of patient care ownership as something that could be a goal or a target for us to pursue. And I'm curious if for trainees, if you've noticed any threads, especially in your qualitative data in the interviews, where there's almost like a negative side to the patient care ownership. I'm thinking specifically about people, definitely not me, who may go home and still like chart stalk and look and be very engaged in what's happening with the patients going on and feel very invested. And then as they transition from a trainee position to a supervisor or attending role, how then you navigate the peer level. And so I could imagine a time when having too much patient care ownership could make it more challenging then to navigate the dynamics of other opinions or other people who also feel engaged and invested. So I'm curious if any of that is coming up, if that's the tension, and what your thoughts are.
Yeah, that's great. April was my peer in the Berkeley School of Education program. So she had a very complex question. But I think we actually saw it more in this most recent study where it was sometimes like, it's been shown that if you have a relationship with the patient and their family, then you are more invested in their care and have more of a sense of ownership over it. But that was sometimes what was preventing the resident from looking to find out what happened, because it was like they would say, I didn't have the bandwidth, or like I couldn't bring myself to look and see what happened to the patient. And so it can become a barrier to be able to do reflective practice. And I think there probably is something to being able to trust the system that is prevented when you feel like you are, like you have so much ownership over patient care that if you're not there and something terrible happens, it's because you weren't there. It's not because it's just the way the patient's disease evolved. And so I think that's really interesting. That's kind of me speculating, but yeah.
Hi, Maggie. The last thing you said reminded me of something that Satish would say. It's like, do you really think the child wouldn't have coded if you were sitting at the bedside? And the reality is probably most of the time, no. But we build this narrative in our heads that like, and it's that sense of ownership, but it can tip to a side that becomes detrimental. But one thing I want to just comment is I love your research because it reaffirms my belief and would love to push supervisors to think more. Like I frequently hear as a program director, and I'm sure you have as well, like this trainee is so disengaged. I don't understand, like, why aren't they trying, but instead of thinking about like, what is it about them, thinking about the factors that might be contributing to the fact that they didn't follow up on that lab, or they didn't call that in the timely manner, call that consult in a timely manner. So I think bringing it out of just the cognitive behavioral, but into the psychosocial context is how we're going to actually get learners engaged into what we're doing. So thank you. That's a comment. My question is, you say, let's not think about autonomy, but as somebody who gets an ACGME survey every year that asks me about autonomy and supervision, if you could control the ACGME, what question would you put on it to replace the autonomy and supervision question?
Yeah. I guess this question may already exist. Yeah, I would love to get rid of that question because I think it labels it again where then you're like, the resident's like, I don't remember anyone ever telling me I had autonomy, so I'm going to say no. So I think I would probably shift it to something like, is your something about their experience in the clinical learning environment, if it's which I think this question does kind of already exist. If they feel like they're growing from their experiences, they're growing, that their trajectory is on track because of their experiences in the clinical learning environment. And so that they're reflecting that their experience with patients is resulting in them developing into whatever physician they're training to become. That was a good question. I'm gonna have to think more about. This is what I'll like later today. Be like, oh, I should have said that.
I'm going to make sure that the attendings don't dominate the conversation. I'm going to give some conversation ownership to one of our residents.
Thanks, Sandrine. Hi, everyone. I'm Kevin. I'm a PEDS R2, soon to be R3. I really appreciate your talk today and the research that you do, because a lot of the things that you were describing, I'm like, oh yeah, I did feel that way at some point in my training. So thank you for expanding this field and helping the learning experience be better for all of us. My question is, a lot of the inpatient spaces now involve fellows. So I'm wondering if in your work, if you've studied how the attempting to fellow to resident dynamic evolved through time.
Yeah, I haven't, and I'm like constantly aware. I have like kind of a metacognition going on when I am attending, because I'm trying and not always succeeding in giving the fellow autonomy, but what that becomes is that I don't interact with the residents much at all. And so I think there's like something missing in the learning opportunity there. And I haven't studied it directly, but it definitely comes up. And when I interview with residents is like, well, the fellow, like it can be a focal point of, well, the fellow made me do this, or the fellow didn't ask me my opinion, but it usually just gets bucketed that the fellow becomes the supervisor. But I I like that line of thinking, and it's actually just a lot of fun to talk with residents about this type of thing, and so I really enjoy the openness of residents when I have the interviews too.
Thanks. My question kind of relates a little bit to what April was asking about, that idea of like what you seem to identify early on, that like patient ownership seems like a big motivator for learners. Have you or anyone else looked at what like patients or families themselves use to determine like who owns their care, and does it align with the learners?
If you have any extra bandwidth in your own research, partners. No, I think that is not well researched, and I've thought about doing something where we get more of the patient family perspective. I did kind of a pilot study during my master's where I would ask, after rounds, I would ask the family who they thought their doctor was, and it was almost never the resident. And so I think there's a lot of value in that. And we tried to incorporate feedback from the families, like in the Press-Ganey evaluations that come through. We were trying to put those in the report card residents would get, but it's really hard to attribute the resident to the family because it's usually just linked by billing to the attending of record. But I think that's an important, very like socio-cultural view. Yeah.
Wow, Mike, that's a compliment from Maggie. Even I don't get those kind of compliments. It is a nice segue to two questions that were posted on Zoom. One is from Meredith Laguna, who says in the outpatient setting, there's oftentimes more opportunity for autonomy, and any tips on how you can promote for the residents who are sort of reticent, how you can promote them to engage actually with that opportunity to have that through patient care ownership and decision-making power.
Yeah, thanks, Meredith. I hate to say I definitely have an inpatient lens to my research, and so that's a gap in what I do. When we openly ask residents to just talk about their decision-making experience, the vast majority of the time they did talk about their inpatient experience. And I don't know why that is. I think there were a few places where residents would talk about in the outpatient setting being forced to, maybe that's too strong a word, engaging in a lot more consults than they thought potentially were necessary for the patient. And that happens in the inpatient world all the time too. And then they sometimes talked about when an attending would give them a little bit of wiggle room and like the structure of the day. And so I remember one resident talking about the attending allowed them to skip the like noon lecture so that they could spend more time with a family who they had seen previously that they knew was going to have a really complicated visit. And that had like stood out to them as a way that the attending allowed them to have a little bit more ownership in the patient care. But I will say I don't know a lot about that context yet, and I should try to incorporate that more.
And then Devan observed that there's so much complexity now in our academic children's hospitals, which explains some of this data, and whether there's been any effort to push residency training more to community hospitals.
I don't know. There's people in this room who would know better than me those types of efforts, but I do think that all the conversation around shortening fellowship training in a way is a result of trying to balance the idea that we're pushing trainees into academic careers too much that may not be interested in academic careers. And so that's the like making the fellowships 2 instead of 3 years. I think my response would be, I hope that doesn't happen, because I think complexity is only going to become more ever present in our work as physicians. And so I think it's actually we should think more about how to make sure learning is happening even in the face of complexity.
And I can tell you, my answer to Devon was like, sure, but who's going to pay for that, right? Nobody will pay for that.
Yeah.
I think along those lines, a lot of the community-centered care, a lot of the community center care in San Francisco has been contracting, and centers are actually closing down. So consistent with the financial issues there.
Perfect. I think we're at the end of the questions and at the end of time. So